Please go ahead.
Well, very good morning to all of you, and good evening and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Shankara Panisha from Birmingham, UK, and he's going to lecture us on Zanubrutinib, the new kid on the block. This webinar, as usual, is brought to by Mumbai Hematology Group, supported by Glenmark, Unipath, Natco, Lucian, and Nirvid Life Sciences, and managed by Perfect Square. I thank Mr. Amaninder Dillon and team from Glenmark. I also thank Nirvin, Lucian, Natco, and Unipath for supporting our academic activities. Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Rajiv Dey from Kolkata. Our guest speaker for the day, Dr. Shankara Panisha from Birmingham, UK. All our discussants, who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give flavor of our next weekend activities. Next Saturday, that is 21st of February 2026, from 7 p.m. Indian Standard Time and 8:30 a.m. Central Time, we have Dr. Eunice Wang from Buffalo, New York, speaking to us on acute myeloid leukemia highlights from ASH December 2025. And the following day, that is Sunday, 22nd of February 2026, we have got two lectures. Lecture 1 is scheduled at 11:30 a.m. Indian Standard Time. We have Dr. Shweta Pathak speaking to us on unusual presentations of pediatric leukemias, lessons to learn from real cases from Jabalpur, India. And following this lecture, 12:30 p.m. Indian Standard Time and 8 a.m. French Time, we have Dr. Regis Pifolti-Latour from Paris, France, speaking to us on paroxysmal nocturnal hemoglobinuria. Let me introduce our discussions for the day, and we have galaxy of them here displayed alphabetical order. I will pause for a while for you to look on all our discussions for the day, who are very eminent hematologists, hemato-oncologists, as well as medical oncologists all across the country. So some more over here. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have with us no other than Dr. Shankara Panisha from Birmingham, UK. We all know Dr. Panisha very well. He has been the speaker multiple times on this platform, but it's my formal duty to introduce Dr. Panisha to all of you. Dr. Shankara Panisha is consultant hematologist, honorary associate clinical professor at Birmingham Center for Cellular Therapy and Transplant and University of Birmingham, Birmingham, UK. He is a consultant hematologist with over 2 decades of experience in the treatment and management of blood disorders, including leukemia, lymphoma, and myeloma. He sees patients at the Queen Elizabeth Hospital, Birmingham, the Spire Little Aston Hospital, and the Spire Parkway. He earned his primary medical qualification at Mysore University, India, and later earned his degree in general medicine at Bombay University. He then undertook his basic training at the Royal Marsden and Royal Free Hospital, after which he completed his specialist hematology training at the prestigious West Midlands Deanery. He then focused his career on myeloma and venous thrombosis research at Warwick University, where he gained knowledge and expertise in the treatment and diagnosis of those disease areas, in addition to the effective treatment of lymphoma, myeloma, inherited thrombophilia, and stem cell transplant. Upon completion of his research, he was appointed consultant in 2017 at the Heart of England NHS Foundation Trust, where he has since been appointed principal investigator as well as sub-investigator for several hemato-oncology clinical trials. He is also actively involved in scientific research and has authored several peer-reviewed articles in renowned journals and medical journals. He has also presented his research at national and international conferences. Today is with us and he's going to lecture us on Zanubrutinib, the new kid on the block. But before he does that, let me introduce our special guest and chief guest for the day, my teacher, Dr. Rajiv Dey from Kolkata. Let me introduce Dr. Rajiv Dey to all of you. He is Professor, Department of Hematology, Nodal Officer, Multidisciplinary Research Unit, NRS Medical College, Kolkata, Clinical Lead, Department of Clinical Hematology, Hemato-Oncology and BMT, EC Member, ISHBT, Nodal Officer, EIB MCT. It's my privilege to welcome Dr. Rajiv Dey to inaugurate a webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Rajiv Day.
Thank you, Dr. Amit. It is again a privilege to be introduced by you because I worked with you a long time before where I am still working. And very good morning to everybody. I express my sincere regards to our MB Agarwal sir because just having confidence on me that I have also something to tell, to give some message to the young hematologists and the students of who are studying hematology in India. Now, I started my hematology career long time back, 15 years back. I passed DM hematology in the year 2010. And at that point of time, the hematology training was in a budding stage in India because there are very limited seats. In West Bengal, there was only one seat at that point of time. Now there are 7 seats every year. When I did my DM from a resource poor setting, it is a government hospital, and just only the year before it was started, DM hematology in West Bengal. There are a lot of disadvantage of getting trained in a resource poor setting. We all know. But there are a lot of advantages also getting trained in a resource poor setting. So when you work in a resource poor setting, you learn the art of utilizing all the resources, whichever minimum you have there. One most important is patient. So there was no dearth of patient over there. So we learned the art of clinical medicine. So how to get clinical findings from whatever patient is providing, history, clinical examination. Number two, the limited amount of tests which were available at that point of time, we tried to interpret as much information possible from those available informations like CBC, complete blood count, liver function test, LFT, and flow cytometry machine was there at that point of time. At that point of time, there was no division in our department as clinical hematologist and hematopathologist. So we need to do the clinical work. Then we need to interpret the slides. And then depending on that, we had the lab where we used to run the flow cytometer and we also treat the patients. So that's why we learn the clinical hematology as well as hematopathology. And we didn't wait to get the report. That is, the hematopathologist will give this case as an acute leukemia, then I will treat. Just we will see slides, take the decisions, and this is the advantages of getting trained in a resource poor setting. In last few months, I attended 3 premier institutes of India as a DM final examiner. What I found was that the students were excellent in knowledge, recent advances, and interpreting the most recent investigations, mutations. But there was a lack in art of clinical medicine. So that we need to learn. So that is my message to all budding hematologists and students, that you please learn the art of clinical medicine. And I tell you, it won't take more than 3 to 4 minutes time to examine a patient from head to toe. That 3 to 4 minutes time we need to give to a patient. Number 2 is interpreting the basic hematological investigations. In the CBC, lot of informations can be get from the CBC, from LDH, liver function test, reticulocyte count. So please interpret those investigations before going to NGS and further. And number 3 is don't whoever in the specific clinical hematology or hematopathology, I think all students are there here. So don't keep that barrier that you can't cross the barrier. So please go to the lab, those who are in clinical, hematology, see how they are reporting, do the reporting, and those who are in hematopathology just come toward, see the patients, because hematology is a subject where you need to have a proficiency both in clinics as well as in lab. I think no other, just subject has that kind of, interdependency between lab and clinics. And uh, I use, then I think you should focus on four things. Number one, definitely your clinics. Number two is laboratory. Number three is research. And research doesn't mean that you need to do some path-breaking research. Some research are only possible in resource poor settings because which are not possible ethically in the other part of the world. So that is our problem. And you need to identify those small issues and do some kind of research. And under DHR, Department of Health Research, many medical colleges, as well as government and private medical colleges, has multidisciplinary research unit, MRU, where you can do a clinical research with a limited grant. And number four, and most important, is teaching, which MB Agarwal sir always say that teaching is a way of learning. You don't need to be a professor of an institute to become a teacher. As a student, you teach whoever you are getting. You teach your juniors, you teach your nurses, you teach your supporting staff also, you teach your patients relative, patients. So that way you can learn. So when we counsel a patient, we many of times we give a vague information. That is, it is a bad disease. The patients won't survive for long. But please give a informed informations, informed counseling. What is the possibility of a long-term survival? What is the complications you will face? So in that way, you are also teaching your patients and caregivers. In that way, I think, and other high-end investigations, high-end teachings, they are there that you will learn by the process of your curriculum. And again, of all teachers, MB Agarwal sir is there. I first attended the comprehensive hematology conference in India way back in 2008 in hematology to today. So at that point of time, all the students used to come, and it used to be in the December, January time before our examination. So it was a revision kind of thing. And I also express my sincere regards to MB Agarwal sir, because after passing, I got the first faculty invitation in hematology today as a speaker. So this is the small messages from my side to all the students and junior hematologists. And the future is bright for hematology because the horizon is expanding every day. There is no limit of the knowledge and expansion of hematology.
Thank you, Dr. Rajiv De sir. Wonderful words. Fantastic. It just brought me to the student life about 15 years back when you were my teacher. The same words have been repeated again. And the basic investigation part, which you said, was absolutely correct. And one must learn to harbor the basic investigation knowledge. And really true, wonderful words, inspiring words to all the budding hematologists, and for that, very important for all the students in hematology. Thank you, sir, for being our chief guest for the day. Wonderful, excellent, superb speech, sir. Thank you, sir. And now,
Thank you, Amit. Yeah.
Dr. Panisha, the screen is yours. Please go ahead.
Amit, thank you very much for the kind introduction. And on this very special cosmic day of Mahashivratri, it is delighted to be with you. And I think you started off with a bang, and then which is continued by Professor Rajiv Day, the importance of teaching. And I'm so grateful for all the teaching between 93 to 96 with Prof. Agarwal. So we have Prof has given me a very exciting topic on this Mahashivratri day, Zanubrutinib, the new kid on the block. We know so much. Uh, about the BTK inhibitors. We have covalent BTK inhibitors and non-covalent BTK inhibitors. At this stage, we will have a long discussion about Zanubrutinib. Perfect Square team, can I take over the control of the slide, or do you want to run the slide? If I can go to the next slide.
Kalpesh, if you can give
Yeah,
me.
sir, you have the control. Yeah.
Yeah. Okay, thank you. So what I want to do over the next 45 minutes is to have a bit of introduction to the covalent BTK inhibitors, how we came to this. Because Prof has given a very exciting topic, and Zanubrutinib is the one BTK inhibitor which is licensed in CLL, margin zone, Waldenstrom, and mantle cell. We'll look at the data. And the most important, because it's always Prof and Amit make sure the discussion bit is very interesting. So I want to go through the have a discussion. With this, what I wanted to highlight is when I started my hematology training in the later part of the previous millennium, we had access to the limited drugs. And when I was working with Prof between 93 to 96, we didn't even had fludarabine in India at the time, and not rituximab. So if you look at this slide, how much progress we have made in terms of the chemoimmunotherapy from 1949 to where we are. And the second decade of this new millennium is all about the BTKI. And this is slide shows some of the timeline of the immune treatment with the rituximab entering in the low-grade lymphoma, in the high-grade lymphoma setting in the 2000, then gradually coming over based on the German CLL trial for the treatment of the CLL. But what really changed in the later half of the first decade of the millennium is the recognition of the B cell signaling pathway with the role of BTK inhibitors and then the BCL2 inhibitor venetoclax. We are now blessed to have not only the covalent BTK inhibitors, non-covalent, and also significant data is emerging from the role of the BTK degraders. Now we know so much about the site of action of the BTK inhibitor. For people who have already read a lot of Nathan Wardy's, the book For Blood and Money, you know how the ibrutinib came and all the hard work Robert Duggan had to do to get the ibrutinib into our clinical practice, and the change it has done in the management of the CLL. I just wanted to highlight how we are having first, second, and the third generation BTK inhibitor. This chart shows the different the kinases that are inhibited from the ibrutinib, and the whole concept of having the next generation of the covalent BTK inhibitor is regarding the specificity. If you look at the kinome chart of the ibrutinib, there are lots of big red dots, which means there is an off-target inhibition of other tyrosine kinases, which is causing some of the side effects, maybe also to additional activity. As you can see, acalabrutinib, few dots, but the byproduct of the acalabrutinib called M27 or what is ACP 5862, it has got a similar to the ibrutinib, slightly more off-target effect. As it comes to Zanubrutinib, you can see that is again targeted, And the most important with the Zanubrutinib is the level of the BTK inhibition with either twice daily dosing or once daily dosing. With this, I just wanted to run through what was the timeline for the Zanubrutinib in terms of the FDA approval. I know different countries, the regulatory approval is different, but within 10 years from the ibrutinib coming into picture in November 2019, Zanubrutinib had an accelerated approval for the relapsed refractory mantle cell lymphoma beyond one line. Then for Waldenstrom in 2021, then marginal zone lymphoma in 2021, the chronic lymphocytic leukemia, the full approval, that is both for the front line and for the subsequent line treatment. And then in 2024, Zanubrutinib along with obinutuzumab was approved for relapsed refractory follicular lymphoma once patient had two prior lines of treatment. Now, how did this approval came in? So this is a slide where I have summarized the main clinical trial which led to the approval in this indication. If we take the CLL first in the treatment naive population, the Sequoia trial, which had two different arms, one cohort 1 is patient with intact 17p. Here, of patients, nearly 480 had bendamustine rituximab or zanubrutinib. And you already aware of the presentation in the last ASH in December 2024, where we had a 6 months, 6 years update showing people on zanubrutinib had a 74% chance of being still on the drug. When you look at the cohort 2, which is for people with the 17p deletion, again, 64% of the patients are still on zanubrutinib after 6 years of the treatment. For all of us who have managed difficult 17p patients, it is such a remarkable change when we used to use methylprednisolone, when chemotherapy was not useful. The overall survival of patient with 17p deletion used to be less than 2.5 years. Then we have the relapsed refractory CLL, where the zanubrutinib is compared with the ibrutinib with over 650 patients, and the study is still having an extended follow-up. We have the data at 4 years, which showed zanubrutinib is superior to ibrutinib. We may pick this one up in the discussion how zanubrutinib is different to acalabrutinib from the Elevate RR. Then 230 patients in the Waldenstrom, again, another topic for discussion between the the cohort 1, cohort 2, where the cohort 1 had patient with a mutated MYD88, and then the cohort 2 had a wild type, and how the effect is different between the two covalent BTK inhibitor. The orphan disease margin zone lymphoma, just under 70 patients, and in a 2-year follow-up, and we still, like the CLL, 72% of the patient are still on the drug beyond 2 years with significant improvement. And then relapse mantle cell lymphoma. We'll look at this data later on. All of our treatment are mainly run through the different clinical trial. This is the recently updated the British Society of Hematology guideline, which was presented only last year. It was published October 2025. You can see how zanubrutinib is the one of the BTK inhibitor, which is as a continuous treatment. Now the Zanubrutinib with the other BCL2 inhibitor as a fixed duration treatment, which is going through the clinical trials. And this is something for us to explain. The same guideline from the different countries. This is the European guideline ESMO, and then I also have the German guideline here, which again introduces how the BTK inhibitors have revolutionized the practice of management of the patient with chronic lymphocytic leukemia. I haven't put in the NCCN guideline, but the NCCN guideline is similar to these guidelines. Apart from in US, there is no access to ibrutinib and venetoclax. Just to go through some of the clinical trial information in greater detail, the study which allowed FDA registration for zanubrutinib is the Sequoia trial. This had two cohort, as I was alluding before. The cohort one had just under 480 patients. These are patients with intact 17p. Here, patients were randomized between zanubrutinib, 160 milligram twice a day, versus bendamustine rituximab. For all of you, you're fully aware of the other frontline CLL trials like Elevate TN or the German CLL 14, where the comparator arm was chlorambucil obinutuzumab. You will notice bendamustine rituximab is a much better comparator arm. You would also note even in the GLOW clinical trial, which is ibrutinib venetoclax versus chlorambucil obinutuzumab, the comparator was CO. The cohort 2 had just over 110 patients with the CLL with a 17p deletion. The primary endpoint for this trial, which I will take you through, is the progression-free survival, whereas secondary endpoint had overall survival. If I show you the Kaplan-Meier curve showing the so this is patient characteristics, and you can see there is not much of a difference between the zanubrutinib arm and the bendamustine rituximab arm in terms of the patient baseline characteristics, including the genetics. Other than there was two patients in the zanubrutinib arm were subsequently identified to have a 17p deletion, but the number doesn't meet statistical criteria. Now, if I show you the Kaplan-Meier curve, which is done at the initial presentation, what they showed is this nearly 60% reduction in the risk of progression. So at the point of primary analysis, so at 2 years, 86% of patients with the zanubrutinib are in ongoing remission as compared to 70% of patients with bendamustine rituximab. And the benefit got better with the extended follow-up. Now, all of you who remember well the outcome from the German CLL 14 trial, the three factors were associated with the inferior outcome even in patients receiving venetoclax obinutuzumab. These are one patient with a 17p deletion of the TP53 mutation. The second is a patient with the IGVH unmutated, or patient who had a lymph node size of more than 5 centimeter at the point of starting venetoclax, obinutuzumab. But you can see from the Sequoia trial, the continuous BTK inhibitor, the zanubrutinib, is overcoming the negative impact of the IGVH unmutated status, and there is no significant drop in the Kaplan-Meier survival curve, even when you look at the follow-up at 5 years beyond the initiation of the treatment. Now, what about the patient if they do have a 17p deletion? This is the cohort 2 of the Sequoia trial. 90% of the patients are still in progression-free survival at 2 years. This is when the initial data was presented. But if you look at the latest update presented in ASH last year, at 6 years, 72 months, the overall response rate in the CLL cohort is 98%, and 74% of patients are still 84% still on the drug progression-free survival, whereas 64% of patients with the 17p deletion are still on zanubrutinib, giving a significant therapy option to our patient with CLL. To summarize, the Sequoia trial, which showed that zanubrutinib is superior to the chemoimmunotherapy in the form of bendamustine rituximab. This was both in the cohort of either with an intact 17p or in patient with the 17p deletion. With an extended follow-up of 6 years, the benefit continues to get better. I didn't have the time to go through the side effects. There were no any new adverse event noted other than what we already know from the different BTK inhibitors. Only thing to highlight, the risk of atrial fibrillation, bleeding, and the cardiac event are less with zanubrutinib as compared to ibrutinib. Now, this was the data on the frontline patient. So what do zanubrutinib do in patients with a relapsed refractory CLL? Alpine or BGene 305 is the clinical trial where over 325 patients were randomized between zanubrutinib and ibrutinib, with over 325 patients in each arm. Here, the primary endpoint was mainly looking at the overall response rate, and the secondary endpoint was the progression-free survival. What the data clearly showed is patients, even in the relapsed refractory setting, being on zanubrutinib, even at the point of the primary analysis, there is more than 1/3, 35% risk reduction in risk of progression as compared to ibrutinib, and this protection or the risk reduction significantly increased on extended follow-up. And as you can see, majority of the patient group here were benefited being on the zanubrutinib, and only the 2 cohort who did not get significant benefit is one with a relapsed CLL patient with a mutated, or patient with more than 3 prior lines of treatment. In everyone else, being on the zanubrutinib, it was superior. And what was even more exciting from the patient perspective is if you do have an adverse genetics in the form of the 17p deletion, the benefit for the zanubrutinib was much better as compared to ibrutinib. At the point of extended follow-up at 40 months, overall survival is a trend towards the zanubrutinib being superior, but the p-value is still 0.09, so it does not hit the statistical significant, whereas both overall response rate and the progression-free survival are statistically significant. And what's even more exciting, not just the efficacy, but the side effect profile showed that the risk of atrial fibrillation, hypertension, and the bleeding symptoms were significantly better with zanubrutinib as compared to ibrutinib. So this is where the results of Elevate RR, which is acalabrutinib and ibrutinib, and the Alpine with the zanubrutinib and ibrutinib bit different, whereas acalabrutinib was non-inferior in terms of the efficacy, but it was much better in terms of the side effect profile. Whereas in Alpine study, zanubrutinib is superior both in terms of the clinical efficacy and also in terms of the side effect profile. This again, to some extent, is highlighted by this 215 study where patients who were either on ibrutinib or acalabrutinib when they had a intolerance. The key point I wanted to highlight is this is a study of patients who with the CLL who are intolerant rather than progressive. They received zanubrutinib either at 320 milligram once a day or 160 milligram twice a day. So it had just under 60 patients with ibrutinib and 35 patients with acalabrutinib. And clearly, the study showed that patient tolerated zanubrutinib much better after a follow-up of just over 2 years. Uh, and, and the duration of exposure of zanubrutinib is nearly 2 years as compared to just under 9 months and 5 months with either ibrutinib or acalabrutinib. And the key is 2/3 of patients who were intolerant to ibrutinib or acalabrutinib never experienced the similar the side effect, and zanubrutinib was efficacious, highlighting if there is an intolerance with either ibrutinib or acalabrutinib, zanubrutinib is an option. But I want to highlight the most important point. This is in patients who had not progressed, but only intolerant. Now, just changing from CLL to mantle cell lymphoma, how is this data? The 206 included 86 patients with a relapsed refractory mantle cell lymphoma for at least one line of treatment. They received zanubrutinib at 160 milligram BD. This is mainly looking with a primary endpoint of overall response rate. And out of the 86 patients, over nearly 50% of patients still continued on the treatment at the point of reporting. Some of the dropout is because of the progression with a median follow-up of nearly 3 years. What clearly shows is at least 50% chance of being in remission at the mantle cell lymphoma, by being on Zanubrutinib. This is a remarkable success for this cohort of patients with a difficult to sustain remission, being on simple oral drug, being on remission at 3 years is the 1 in 2 chance of being in remission. A remarkable good news. This is the summary of the 306 trial, clearly highlighting the role of Zanubrutinib in the relapsed refractory mantle cell lymphoma, which led to the FDA approval. So the key thing is to highlight the cardiac side effect, atrial fibrillation, or hypertension with slightly reduced in incidence as compared to the CLL cohort. This may explain by the median age of mantle cell lymphoma, maybe about 10 years younger than the median age at which the CLL patient do receive medication. The question for all of us is, where do the Zanubrutinib stands among the BTK inhibitors? And I just put here a comparative slide looking between the ibrutinib and the acalabrutinib. The key is there is no significant differences in the side effect profile. As you can look at the neutropenia and the infections are similar. But the key with the zanubrutinib is the overall response rate appears to be higher. It is exciting times when we all had the frontline data with the SHINE study BR plus ibrutinib, or with the ECHO trial BR plus acalabrutinib. We do have an exciting time. Hopefully, we'll get more discussion during the discussion to explore the triangle data. Now, changing from the mantle cell to margin zone lymphoma, again, the current day Waldenstrom is a disorder of two key genes, either mid-88, because majority of the patients are mid-88 mutation, up to 95% of patients, and only minority of patients are mid-88 wild type. And then is the CXCR4 mutation status, where 60% of may be mutated for CXCR4. We have a conflicting data regarding the mid-88 status and the response to the BTK inhibitor, with the wild type having less responsive to BTK inhibitor as compared to the mid-88 mutated. So this is why in this clinical trial, the patient with the mutated were randomized to have ibrutinib and zanubrutinib, whereas the mid-88 wild type had a single arm receiving the zanubrutinib. And in terms of the number, nearly 100 patients were randomized to both ibrutinib and zanubrutinib. What the primary analysis showed was not much of a difference between the overall response rate between zanubrutinib and ibrutinib, maybe marginal difference where the plot thickens, or is that the VGPR status was much higher in the zanubrutinib arm as compared to ibrutinib arm, but the progression-free survival on extended follow-up was better with the zanubrutinib, with just under 40% risk in the progression. But this story is always more interesting once you look at the mutation analysis, with patient who are CXCR4 mutant had a better response with Zanubrutinib. You can see here patient who had CXCR4 mutant had a 1 month progression-free survival as compared to 10 months the ibrutinib. This difference is much less once you take the CXCR4 wild type, suggesting zanubrutinib may be a better drug if you have a worse genetic situation, is either in the form of the CXR4 mutant or MYD88 wild type. The marginal zone lymphoma is another exciting condition where first-line treatment may be the antibiotic, looking at the H. pylori eradication. Where the treatment gets difficult is once patients had a chemoimmunotherapy and relapse, we were struggling for options. So here we have a Magnolia trial, which is looking in role of zanubrutinib in 68 patients. And the key is zanubrutinib is agnostic of the type of margin zone lymphoma, whether it is a splenic, nodal, or extranodal. It had a similar efficacy with nearly 70% of patients achieving overall response rate. And with an follow-up, over 70% of patients still being benefited with the being on zanubrutinib. Just to highlight where zanubrutinib stands in terms of the all the other treatment we have been exposed to in the mantle cell lymphoma, the only two types of treatment, zanubrutinib, copolisib, and the CAR T, have a response rate 70% and beyond, and lenalidomide and rituximab is FDA approved, whereas it is not available in UK for the treatment of margin zone lymphoma, and we also don't have access to the ibrutinib. Sadly, even though the PI3 kinase inhibitors had demonstrated a role, FDA has taken the any further studies of PI3 kinase inhibitor because of the side effects, mainly in the form of inflammatory bowel disorder and the TCP infections. In terms of the dosing, the standard dosing of zanubrutinib is either 320 milligram once a day or 160 milligram BD. This comes as an 80 milligram capsule, but this is where I will be benefited by Prof. And Amit. In the Indian setting, this is as per the SPC, 80 milligram of zanubrutinib with a strong CYP4 inhibitor like posaconazole or voriconazole is equivalent to 320 milligram of zanubrutinib. This is one way we can bring down the cost of the zanubrutinib. And I've highlighted here how do we dose reduced based on the side effect profile. On the first occurrence of the serious adverse effect grade 3 or higher, we stop the drug until the resolution, and then we restart the drug. But if there is a second occurrence, we can cut down to 160 milligram once a day. On the third occurrence, we can even go down to 80 milligram once a day. But if the similar AEs occur, then we'll have to discontinue beyond the third trial. So there is this option of dose reducing and getting the benefit. Key point I wanted to highlight is the side effects, mainly the side effects of interest with any BTKI is the cardiac, the atrial fibrillation, hypertension, and then the bleeding. The majority of the side effects are within the first 12 months. This is a slide from the Aspen trial. And as you can see, once we start using the BTKI for a longer time, the grade 3 and higher side effects are minimal beyond the 36 months, and it is empowering our patient regarding the optimization of the blood pressure monitoring. But the risk of atrial fibrillation in the relapsed CLL is significantly better with Zanu. If we have to grade the BTKI as per the atrial fibrillation, Zanu is the best, then the acalabrutinib, and the least favorable for is the ibrutinib. Similarly, for the bleeding risk, only area where acalabrutinib is better than the zanubrutinib is the uncontrolled hypertension. May be much better with acala as compared to zanubrutinib and ibrutinib. In terms of the take-home message, in majority parts of the world, covalent BTK inhibitors have become the cornerstone of our management of low-grade B-cell disorders. I can't remember in the last 5 years I had to use chemoimmunotherapy in the management of the CLL. And if we are looking for one BTK inhibitor for all low-grade B cell like CLL, marginal, Waldenstrom, we have zanubrutinib, and this both second and third generation covalent BTK inhibitor, acalabrutinib and zanubrutinib, have shown to be a better cardiac safety as compared to ibrutinib. And I summarize the main clinical trial, which has allowed us to use the zanubrutinib as a pan-BTK inhibitor in all these conditions. With this, I will stop and we can have a discussion.
Thank you, Dr. Panisha. Wonderful lecture. And now I request all our discussants to please put the hand raise signs so that we can start a question session with Dr. Panisha. Sir, if you can just unshare your screen once.
Perfect Square has to do that.
Yes.
Kindly stop sharing the screen. Perfect Square. Yeah. So Panisha, till others ask the questions, first of all, I compliment you for a very comprehensive review of this new kid on the block. As the drug is available to us with the help of financial support, we've started using it for the last couple of months, and we have some kind of feel of this molecule. And you brought it out beautifully how it is safer and more effective than the other BTK. As you use the word pan B cell, I mean, I think it's not even important to know which disease you are facing, whether it is CLL or mental or marginal or Waldenstrom. It just cuts across all the conditions, and whether it is upfront or relapse setting, and whether it is a bad genetics or good genetics, you need not even probably do the IGHV mutated, unmutated, 17p deletion, not deletion. It just works everywhere. So that kind of beautiful aspect that you brought out And together with, the scare we had of using ibrutinib when it came, the patients sometimes getting cardiac deaths also, and bleeding, interfering with a lot of patients who are elderly and taking anticoagulants, antiplatelet drugs. It's beautiful. I mean, what you did was a wonderful job. Thank you and compliments.
There is a question regarding the Zanubrutinib minimal dose and the longest interval. In terms of the dose, it will depend upon any concurrent medication. The standard dose would be either 320 milligram once a day or 160 milligram twice a day. And I think this is again a discriminator between the other BTKI. Ibrutinib, we had the luxury of using 420 milligram once a day in CLL or 560 milligram once a day in mantle. Whereas between the second generation, the acalabrutinib has to be 100 milligram twice a day. And with the previous preparation of acalabrutinib, there was it wasn't suitable to be used with H2 receptor agonist like the omeprazole, whereas the newer preparation, that is not an issue. Whereas with zanubrutinib, there is no such restriction. Again, some of patients may prefer to take the drug only once a day, so we can use 320 milligram as compared to 160 milligram twice a day. Regarding the age, there is no difference. We don't have any evidence to say there's any issue between the middle age and the old age. And I do have some of the CLL patients who are on zanubrutinib in clinical trial now coming up to 8 years and still efficacy maintained. And I have some mantle cell lymphoma patient beyond 4 years. So the duration of BTKI in mantle cell lymphoma is entirely dependent on the response they achieve. So if they are achieving an complete metabolic remission by 3 to 6 months time, then they're likely to be on the longer term. Regarding the perioperative management of the BTKI, it is the same guidance as whether it is a mild, moderate, and surgical intervention. For mild to moderate, the general guidance is to stop 3 days before and 3 days after. But for a major surgery, it is 7 days before and 7 days after. But with every patient, we might have to personalize dependent on how well they were in remission and the nature of the remission, because some patient with a brittle control may not want to give a longer period, because stopping for 14 days sometimes with the BTKI can give to a significant flare. So it's a personalized decision making for each patient. Krishna Natham has asked a very interesting question. Where do pirtobrutinib stand as compared to the zanubrutinib in CLL? So, Krishnaratham, I can't give you a direct answer, but I will go in a roundabout way to answer this question. So we have a data in the relapsed refractory setting between the ibrutinib, acalabrutinib, and zanubrutinib, where ibrutinib and acalabrutinib are similar efficacy, whereas acalabrutinib is superior in terms of the side effect profile, whereas zanubrutinib is superior to ibrutinib both in terms of the clinical efficacy and also the side effect profile. From the frontline setting, we don't have any clinical trial, but we do have the new, now the statistical way of analyzing is a matched adjusted analysis, MAC, in which depending upon who has done, one drug may be better than the other, but you clearly know the recent MAC showed Zanubrutinib is superior in terms of the progression-free survival. But I need to be very careful in saying this is not a randomized trial, but this is a matched comparison analysis looking between the elevator TN and the Sequoia data. In terms of the Pirtobrutinib and Zanubrutinib, we don't have a head-to-head study. It is possible Pirtobrutinib may be better, but I can't answer that question. We will have some data between first-line Pirto or, but the key is the what type of BTK resistant mutation we get with the different BTKI. Generally, if patients on a prolonged dose of ibrutinib, you get a common C481, which can be easily be overcome with a pirtobrutinib, whereas with the second and the third generation BTKI, it is possible you may get more complex mutation, including the gatekeeper mutation, which may or may not be overcome by PERTA. But in our clinical practice, we do use PERTA before we use others because beggars can't be choosy because we don't have many other options. In terms of the headache, somebody, Sham has put a very interesting question. One of the side effects from acalabrutinib with the initial days is the headache. But we learned caffeine is the best answer to this. So particularly in America, where they have a paracetamol with the caffeine, let use, and whereas Zanubrutinib, the headache is not an issue like the ibrutinib. So as far as the initial headache is concerned, if we have to score the BTK inhibitor, Zanu, then ibrutinib and Acala is. But regarding the financial component, you may come to a different conclusion. So if you can use 80 milligram of zanubrutinib with the voriconazole, which may be cheaper, which is equivalent to 320 milligram, that is a one way of doing. In terms of the European perspective, where we are, the zanubrutinib is the most cost effective based on how it has been funded. But we need to work out country by country.
True. Thank you, Dr. Panisha. Another question is again from Dr. Jyoti Sharma. And how many patients need dose reduction and dose discontinuation in your clinical practice?
This is another great question because, we looked at that the 215 study. If you look between ibrutinib, zanubrutinib, and acalabrutinib, the dose reduction and the discontinuation with the zanubrutinib is significantly less. In my clinical practice, less than 20% of patients need dose reduction in zanubrutinib as compared to 30 to 40% of patients with ibrutinib and about 30% of patients with Acala. So if you wanted less headache, and as Prof clearly alluded, in a say Ramban in Hindi, there's the one panacea for all disease. The zanubrutinib appears to be at this stage. I'm sure the non-covalent BTK inhibitors may trump in 5 years, but as far as the 2026 is concerned, the zanubrutinib appears to be answer to major thing. Amit, Shilpa Gupta has raised her hand. I don't know.
Yeah, Dr. Shilpa Gupta, you can ask your question.
Yeah, good morning, sir. Good afternoon, sir. It is really wonderful to listen to you. Thank you, Dr. Amit, for the opportunity. So, sir, with the recent data of CLL17, the fixed drug combination coming in, the comparator arm was ibrutinib, which probably looks like as if it's redundant. So do you think the ideal comparator would be Zanubrutinib? And do you think Zanubrutinib would be a better choice than the fixed dose combination?
Great question. This is always my personal view is the direction of the travel would be a fixed duration as compared to the continuous. I will tell some of the reasons why it may be. When you look at the fixed versus continuous, the BTK resistant mutation is almost unheard of, minimal when you're on a fixed duration treatment. Whereas all the BTK resistant mutation only happens when people are on continuous treatment. And again, with the continuous treatment, if you take the ibrutinib at 6 years, about 65% patient will be on ibrutinib, about 70 on acalabrutinib, and about 75% of patient will be on zanubrutinib at 6 years. In terms of health economics, if you look at with a fixed duration, I plus V for 15 months, A plus V is 14 months. We don't know the zanubrutinib and sorantoclax, because highly likely the combination will be zanubrutinib and sorantoclax, because rather than a zanubrutinib and venetoclax, because both zanu and sorantoclax being from one company, that may be even shorter. So the cost of the treatment will be limited as compared, and then the side effect profile and the burden of the cardiac optimization and a continuous treatment will be higher. So I feel from a global health economics perspective, we are more likely to move towards time limited. And in terms of the patient preference, always the drug holiday, the treatment holiday, and I think being not on the treatment must be significant benefit to patients. I feel continuous treatment will, apart from the 17p deletion, I do mean to make sure certain high risk disease, it may still be the standard, but for a non 17p deleted CLL, the future is a fixed duration treatment.
Thank you.
Thank you, sir.
Thank you, Dr. Shilpa. Sir, I have a question for you regarding mantle cell lymphoma. We have got numerous variants: blastoid variant, pleomorphic variant, high Ki67, LDH very high, SOX11 negative. So in those patients also, will the Zenu work very well, plus TP53 mutation? So all variants, high risk variants, will Zenu will be still the best one?
This is Amit, as always, you threw a googly. So this was a Shane one googly. It is very difficult because the moment you have a blastoid, now if we look at the way I will answer this question is to go through the ENRICH study, which was come through from the UK, where David Lewis presented ibrutinib rituximab versus chemoimmunotherapy. Unfortunately, the blastoid variant, the BTKI, may not be that effective, but it may be still better than the chemoimmunotherapy. Whether for the blastoid variant, we may need to think of a ibrutinib, the BTKI, in combination with the chemoimmunotherapy. That may be the and again the 17p deleted mantle cell lymphoma, the duration of response may not be many years with the BTKI, whether ibrutinib, acalabrutinib, zanubrutinib may be difficult. It is similarly, again, even the data of PERTO in this complex genetic will be different. The same way, the Ki67, the higher the Ki67, it will go with the duration of response will be shorter. This is where we may allude into the triangle study, where it showed the Zanubrutinib induction, the BTKI induction, along with the chemoimmunotherapy, followed by the BTKI maintenance, was better than our current standard of autologous stem cell transplant consolidation. So that is why I think if we are facing a patient who has got a blastoid or K67, then it may be better off combining the chemoimmunotherapy with the BTKI. With the BTKI, where we have the data is the triangle. The triangle, the RDHAP, RCHOP, with the ibrutinib, followed by the rituximab maintenance for 2 or 3 years, followed by continuous ibrutinib until progression was superior, and it negated the need for autologous stem cell transplant. In terms of the frontline setting, whom we thought not suitable for autologous stem cell transplant, we have two main study. One was the SHINE with BR plus ibrutinib, and then we have the ECHO BR plus ACALA. The SHINE had a better overall survival, but the progression, there was more cardiac death. And as you recollect, the Janssen and pharmacyclics took ibrutinib out in the in USA. So there is no ibrutinib for frontline use in USA. Whereas the study from the ACALA, BR plus ACALA in the ECHO shows that this is a significant better option. The progression-free survival is much better. And again, as Prof was saying, the cardiac side effect profile was much better with the acalabrutinib as compared to the ibrutinib. So that is a point. Your question regarding the SOX 11 is another interesting, because the SOX 11 positive, so the cyclin D1 negative and the SOX 11 positive mantle cell lymphoma do worse as compared to where it differs is if you have a leukemic mantle cell lymphoma, and if their SOX 11 positive, they have a good prognosis. This is the one they almost behave like a CLL, where we can watch and wait. Whereas the lumpy mantle cell lymphoma, who are cyclin D1 negative and the SOX 11 positive, do badly.
Thank you, sir. And one question Dr. Leong has asked. She had a patient of recurrent squamous cell carcinoma of the skin after starting zanubrutinib. Is it the common thing to occur with zanubrutinib, and do I need to stop the drug?
Great question. Again, the second malignancies are known side effect of many drugs. Now, I don't have any evidence to say it is possible, but if you look at the venetoclax obinutuzumab, some of the presentation from the CLL14, particularly some discussion in the 2014 EHA, the second malignancies was slightly higher in the VO arm as compared to the chlorambucil obinutuzumab arm. For Zishin patient, I don't know whether this is a patient with CLL or a mantle cell lymphoma. Patient with the CLL themselves have a slightly higher risk of skin cancer, and nothing to do with the treatment. But my own hypothesis is zanubrutinib is or BTKI are less likely to impact on the T cell function as compared to if you are using a BCL2 inhibitor. Or so that is why if there is a real indication to manage the primary condition, whether it is a CLL or a mantle cell lymphoma, then we should continue zanubrutinib. at this stage, where we don't have any evidence to say that BTKI significantly increase the risk of the second malignancies. It is not the situation like lenalidomide, where there is an SPM is higher, particularly beyond 2 years, or I don't know whether in future we may have an evidence that BCL2 inhibitor may impact on the T cell function. Whereas, as far as I'm aware, the BCL2, the BTKI, they potentiate the T cell function. That is why there is some suggestion that with the CAR T, patient should get a BTKI to actually potentiate the function of the CAR T. So that's one of the reasons why the cell was given with the ibrutinib, and the Transcend CLL4 trial had even when people had progressed on ibrutinib with the cell, they got, and the outcome was much better. So my inherent thinking is BTKI will potentiate T cell function.
Thank you. That was interesting, sir. Dr. Shweta Pathak, your question.
Yes, sir. Thank you, sir. It was a wonderful discussion. Sir, I have a question. In relapsed or refractory B-cell leukemia, where CAR T and HSCT is not feasible, where do you place zanubrutinib, sir? I mean, suppose a patient denied CAR T or HSCT, so where do you place this drug? Can it be used along with chemoimmunotherapy?
It's a great question. In terms of the chemo immunotherapy with the BTKI, as I was mentioning, we had with the mainly in the mantle cell, BR plus ibrutinib or BR plus zanubrutinib. Whereas we don't have in the CLL world, and I think combining chemo with these type of small molecule may less likely to be relevant, because we know Helios trial, which was BR plus ibrutinib or placebo, it never kicked into the practice, because I think chemo immunotherapy may add very little to either the BTKI or the BCL2, where maybe role is what Amit was mentioning in a patient with blastoid mantle or those type of aggressive condition, mantle cell, it may be. And again, in terms of the Waldenstrom and the marginal zone lymphoma, I think it will be the BTKI would be far easier than combining with the because these patients would have already received chemoimmunotherapy and failed. So giving a BTKI along with the chemoimmunotherapy may give side effect profile and not adding much in terms of the efficacy.
Okay. One more question, sir. I have a 7-year-old boy post-transplant. It was a sickle cell disease for which he underwent transplant. He has very refractory GVHD. Initially, he was on steroid for 2 to 3 months. Then, along with that, we have started Jakavi. Now it is a kind of static disease. He still has 4 to 5, 6 loose stool around 180 ml. Consistency is now okay, but still, the Jakavi, since there is economic constraint, so I cannot continue it for long period of time. He's also on sirolimus, BD, and steroids. So I am just afraid how to. Is there any role of zanubrutinib in this condition, sir? Can it be used?
Another great question. The ibrutinib has an FDA license for the management of the chronic GVHD, whereas zanubrutinib doesn't have a license. And this is where the chart I showed of the kinomes may come into picture, because the ibrutinib, because of the off-target BTKI, may be a better. And if I'm not aware the zanubrutinib being used for the GVHD, whereas ibrutinib by its wider targeting of the maybe a better option. Now in UK we use imatinib because again imatinib is used as for the GVHD, but the much better for the lung GVHD. Whereas from what I could hear from your patient is predominantly the gut GVHT is an issue. So here we will be left with the TNF etanercept if you have access, maybe an option. Otherwise, maybe imatinib versus ibrutinib, dependent on the financial situation. But I think it's very difficult to recommend Acala or Zano because of their specificity of the the BTK inhibition.
Yeah. Thank you for your advice, sir. Thank you very much, sir.
Thank you, Dr. Shweta. So I think, sir,
Nisha,
yeah.
I would like you to discuss and your comments on a case. We have a 80-plus-year-old gentleman who had CLL about 15, 20 years ago, initially treated with FCR, then treated with ibrutinib. Then he developed Richter. He went for a CAR T in Israel, got it done, got stuck there because of the lockdown of the pandemic, came back finally. Then he developed a relapse of his DLBCL, which was treated with the use of POLA and other chemotherapeutic drugs. That thing settled, but he developed a CNS disease, especially in the form of meningitis with very hardly any parenchymal disease. We used a combination of Zen with rituximab with lenalidomide with complete remission of his lymphomatous meningitis. Zen has excellent penetration of the blood-brain barrier. I'd like you to comment on this use of Zen.
Great question, Prof, as always, and it is very interesting because there is a study in UK called PRISM, where it is zanubrutinib is. So we do have a regimen called the TDR, which is from US, where based on the ibrutinib, because of the ibrutinib has got a better penetration. The same with the zanubrutinib. Zanubrutinib again as a BTKI, and I think you've done remarkable good job of getting the drug. So if I would have also done the same, the only thing I may have done is the triple intrathecal until because this is predominantly meningitic, so that way until the CSF become negative, and then we could have just continued single agent Xano. And this is remarkably how we will manage the Bing-Neal syndrome, because now some of the Waldenstrom patient, when they get the Bing-Neal with the lymphoplasmacytoid cells in the CSF, it's your patient is Richter's, whereas for somebody at that age exhausted all treatment, I think zanubrutinib is a remarkable good option. And in olden times, we would have given craniospinal radiotherapy, but the toxicity of the craniospinal radiotherapy is significant, and that is where the BTKI, particularly zanubrutinib, and the other maybe the longer the suppression of the BTK has enabled a better control of the CNS disease. And even primary CNS lymphoma and relapse setting, the PRISM study is using Xano.
Yeah, this patient got intrathecal triple therapy twice a week in the beginning and then once a week. And he and his wife were very reluctant for a systemic high dose methotrexate or any combination of drugs to be given systemically on that kind of toxicity. And that's how we just made an anecdotal use of Xeno in this situation. And at the end of the day, we are happy that he's got a lease of life. And he has fought his disease for 15, 17 years. And he got one more little extension of his life over there.
remarkable, great news. And again, what we don't know is whether his CAR T are surviving, because again, CAR T cells are also maybe in the CSF. It's so long ago, more than 5-6 years from the CAR T. The CAR T may or may not be there. And again, Zanu may have potentiated any if CAR T had remained.
Yeah. In fact, this is a very unusual case because he relapsed 5 years after CAR T.
Mm.
The guides said that they have never seen. They would have expected the relapses to occur early or not to occur at all. And he wanted another CAR T, which they were reluctant to offer him. And of course, nothing against CD19, but they said we have got some experimental work going against CD22. And if you're very keen, you can come over. But then he wasn't very keen to go back now. So that's how this was used within Mumbai.
Now, great news from the patient perspective.
Sure. Because he was admitted absolutely obtended, irritable, not recognizing people, and whole family was so depressed what has happened to him. And now he's absolutely, coherent, talking, sensible, CSF cleared. So some lease of life with the anecdotal use of this drug.
We had a similar success with somebody with a Bing Neil who had not responded, and then single agent Xanu.
Yeah.
3 years down the line, the patient is still in remarkable remission, and who was not had a almost like a locked-in syndrome when he had to now completely walking, talking.
I want to quote one more case, which I had quoted just 2 weeks back in one of our web, where we had a discussion on marginal zone lymphoma. This is a male patient from Mauritius who had the marginal zone lymphoma, nodal, treated, etc., in remission, and then relapsed with extensive disease with bilateral massive pleural effusion. And they were so refractory that we were draining 1 liter a day through the pigtail. And this went on for about a week, and we didn't know where will we end. And this chap, within a month of Xeno, he's got no pleural effusion left in his body. So that was another very anecdotal case where we made use of Xeno.
No, I think it's in line with the Magnolia study.
Yeah, absolutely. And like that CSF case here, I mean, we were very frustrated taking 1 liter out of each pleural cavity daily. We didn't know where are we going. And wonderful. I mean, these are great agents with great efficacy, however transient it may be. I don't know how long this effect will last, but these are great clinical benefits. Recently, I read, yeah, yes, go.
Extrapolation, 70% chance of being in remission at 2 years.
That's great.
Yeah, maybe it's a good as compared to otherwise this patient may or may not have survived the initial 3 months.
True. In fact, he could have succumbed to all this losing fluid from his body. How long to replace the fluid and the proteins? His albumin was down to 1 gram and things like that. I want you didn't discuss this entity of follicular lymphoma. We don't yet have bispecifics very easily available in this country for follicular lymphoma. As a third, fourth line, now I have one patient where we have started Obinu with the Xeno. Pretty expensive protocol, but we have started that. I like your comments on that.
As always, Prof, you ask a very interesting question. So it has got an FDA approval.
Yeah.
We personally have got no experience, but for us things have changed a little bit because we do have R square with the tafasitamab, where there is and the outcome is good, and highly likely for us, we are more likely to go with either R square with tafasitamab or R square with epcortimab, because this is where the slight difference in terms of and for this situation you mentioned, as per the FDA label, the single agent EPCOR is also suitable, and the EPCOR can be done whereas the trial data of the Zanu and obinutuzumab is remarkably good. And when we were using the compassionate access glofitamab, there was a clear guidance, and just the obinutuzumab. Sometimes if we can't start a glofitamab in the window, we had to again re-challenge with obinutuzumab. Just highlights obinutuzumab being a much better anti-CD20. It can also induce a good remission of CD20 expressing. And luckily for follicular lymphoma, the CD20 expression is about 5-fold as compared to the CLL. That is why maybe obinutuzumab has got a good, but it has definitely has got a role dependent on the individual country, where if you don't have access to bispecific, it's a very good option.
Yes, we were exactly in that situation. This patient has had R square already, and he has had both CHOP and BR based therapies earlier than that. So, in our situation, we were not left with too many options. Either we had to import bispecifics for him, or what was officially available here. We have an access to both Obinu and Zen under patient assistance program. One more use I want you to discuss is about the benign conditions like refractory ITP and Evans syndrome and Zen. Glenmar gave me the paper, and then I read about it, and it looks to be very fascinating. Your comments on these conditions.
Oh, I think they will explode. These wherever we are using B cell inhibition, and I think this will the role of BTKI in will increase, and particularly some of the rheumatological condition and some BTKI, not Xanu, not ibrutinib, are specifically designed even as a for the management of the atrial fibrillation as a anticoagulation prophylaxis. So that is why the land of the BTKI is really changing. This is mainly based on the bleeding side effect of ibrutinib. So the BTKI are modified in such a way that I think the BTKI will be like a CAR T panacea for many conditions, rather than just what we are currently using. And I think it's a great option for us to have, because we already know how to use this drug in different indications. So using them for ITP and wherever we need to B cell inhibition, I think the role will increase.
Yeah. So I was wondering, because these drugs cause bleeding. So I was wondering how to use them in ITP, and then I read about the Zanubrutinib, that it does not have antiplatelet activity and approved by now US FDA. We don't have access to that molecule, but we have got now Zeno. So in a bad case of Evans, etc., it's a wonderful addition.
Yeah, and the key is, like as you say, the oral, no need for intravenous access. So that is why I think the BTK high have completely changed. And the Captain Bruton, who identified Bruton, he never thought it was in a primary immunodeficiency to where the BTKI that has significantly changed our landscape.
Absolutely.
I have one question, right? As Sir said about one Richter's transformation and the meningitis.
Yeah.
With Zenu plus R square.
Yeah.
And there was a mention about tardy R has got increased risk of aspergillosis. So is this BTK inhibitor doing aspergillosis when you combine it with R square? So we need to be vigilant about it, or is just the tardy R combination only?
Oh, I think that's a very great question, Amit. You may have already looked at the ASH publication with the ibrutinib. if there is a concurrent steroid use, there is a significant risk of significant risk of invasive pulmonary aspergillosis. So that is why if there's a need to use steroid when they're on the BTKI, we always watch out closely and use antifungal prophylaxis. The beauty of using the antifungal prophylaxis is we'll also have to reduce the dose of the BTKI because otherwise the toxicity increases. So that is why in where the cost is borne by the patient, so you may actually decrease the cost of the care by decreasing the dose of the BTKI. And if we are using the strong CYP4 inhibitor like posaconazole or voriconazole, the SPC guidance in UK used to use 80 milligram of Zanubrutinib or 140 milligram of ibrutinib. So that way, but I think your question is correct that with the concurrent use of BTKI and steroid, there's a significant risk of invasive pulmonary aspergillosis.
Thank you, sir. One question has come from Dr. Leong regarding the doses of Zanubrutinib. Do you have a special preference for OD versus BD dose?
I think it is all dictated by the patient preference. And if you're on a continuous treatment, compliance is so much critical in terms of the success of the treatment, decreasing the chances of a BTK resistant mutation. I personally prefer once a day, so that is why 320 milligram once a day, because even most of us struggle with the diabetic medication metformin taking twice daily. So I think 320 once a day is better than 160 milligram BD. So and SPC clearly shows both are equivalent, and the BTK inhibition with once a day Zanubrutinib is similar to 160 BD.
In fact, that's a great advantage over ACALA. You can't do this with ACALA at all because it will leave your body without BTK inhibition for half of the day. Here you've got a beautiful cover for 24 hours. And compliance is a huge issue. I mean, you and me also cannot take drugs regularly when it is BD. Yeah, BD is a problem.
Yeah.
OD is such a wonderful thing.
And if you are reducing the dose of Zenu, then lower dose is same as the highest dose, both in terms of efficacy also, because that is the next question is Dr. Leong
Yeah.
has asked.
So it depends on whether we are decreasing because of the, we had an adverse event because we went through grade stage 1, stage 2, stage 3, and the efficacy is similar, and particularly if we are decreasing the dose because of the concurrent CYP for inhibitor, then the efficacy is exactly the same. And now we do have a trial which result should come out soon where different doses of pirtobrutinib are compared. So the pirto is a standard SPC 200 milligram, whereas there is a 60, 120 and a 200 cohort. And that will clearly answer that question with because in the laboratory analysis, the 60 milligram per 2 does do a similar BTK inhibition. So the question is, by reducing the dose, are we decreasing the toxicity, adverse event, and keeping the efficacy the same? Whereas I had no issues if we have to use an antifungal with an 80 milligram of Zanubrutinib, and there is the more of a problem is when you don't dose reduce and give CYP A4 inhibitor, the toxicity increases, either the cytopenia or including the cardiac toxicity.
Thank you, sir.
At the moment, I'm sure you will strongly recommend not to underdose the drug without any data. If you want to underdose it, you must use antifungal agents with it. Monotherapy, if you cut down, then you will not be creating the continuous suppression of the BTK, and you may allow the mutations to take place.
Thank you. Finished all the questions from the chat box. Any other want to discuss or comment?
Always, Prof stole the show by the wise comment at the end. And I think is the outside of the clinical trial, you should never dose reduce for no good clinical reason.
Absolutely. Thank you.
I would just add one more thing. Small experience with Zeno, but with Ibru, we had a lot of problems with the side effects. With Acala, it got reduced. With Zeno, it has got almost nullified. I mean, we don't see, it's like a cakewalk. And I think OD schedule has made the life very easy. So that's a huge advantage. As Dr. Panisha mentioned, more efficacious, less side effects, better compliance. And when you can make it a cost effective by combining it with antifungal, I wanted to ask you one thing. Can you combine with the clarithromycin?
Clarithromycin is also strong CYP A4, so it should be the same 80 milligram if we are giving 250 BD of clarithromycin, because it is a similar interaction as voriconazole and posaconazole or ketoconazole. Now, I don't think many of us use ketoconazole, whereas clarithromycin is widely used. So that's one of the reasons why sometimes when people have an infection, we use levo rather than clarithro if you don't want to dose reduce.
True, true. Wonderful, great. Yeah.
Thank you, sir. So with this, should we come to an end? There are no more questions in the chat box. And so thank you so much, Dr. Panisha, for wonderful, wonderful lecture, wonderful update, and a wonderful question answer session. And I thank all our delegates who joined over here, audience who have participated over here, and discussants who are there today. So meet you next week, Saturday, Sunday, with another beautiful webinars. And very special thanks to Dr. Rajiv Dey, sir, for coming as our chief guest for the day today.
Thank you. Thank you. Thank you, Dr. Ravi. Yeah.
Thank you, Amit. Hopefully, we'll get to see you.
I'm inviting you for Hematocon 2026.
Yeah, Amit is our Hematocon 2026 organizer. So a lot of excellent scientific agenda and along with other things are expected from Dr. Amit.
Thank you.
And also, we get to see the Prime Minister. With Amit, you never know. You may have the Prime Minister there.
Amit has a little fancy for another Amit, so Amit may come. Event management team. Yeah, thank you.
Thank you.
Thank you, sir. Thank you, sir.
Bye-bye.
Bye-bye.